Okay, guys, thanks for tuning in. So today is our first step into our ultimate goal of getting the smartest people in the world, not me, in one room and talking about their systems and how we can integrate them and how they fit so perfectly. So we're lucky enough to have Annie O'Connor in town this weekend speaking on the World of Hurt overview course.
Thanks.
And so what we're going to try to do today is give a little bit of a preview of the World of Hurt system, right? Pain classification in general, and then how that kind of can maybe link into some stabilization and how DNS principles can aid you in helping those patients that have pain, right? Which all of our patients do, and how they interpret that pain. And so this is kind of like our intro to our functional triage right now. So today we're representing some DNS and World of Hurt. So stay tuned. It's going to be amazing.
Welcome, everybody. We have the pleasure this weekend to have Annie O'Connor here with World of Hurt. What we're really excited about is we're going to talk about how World of Hurt fits into our classification system. We are also going to talk about some current concepts of stabilization. So, as you probably already know, we are always constantly working on how to integrate NPI adjusting in with neurodynamics, in with McKinsey, in with DNS, and amongst these other things. So today we wanted to just talk a little bit about some of the new ideas that we talk about in DNS with stabilization. So how we integrate these things together are really important. I think in the research, if you look at Delito and others, they oftentimes tell us that from the beginning we can classify a case and we're just going to stay in that alley throughout the treatment. And the reality of it is a lot of times we're mixing and matching these different systems together within the same patient oftentimes. So knowing when to use which technique is really, really important in the triage of our cases. Okay, so on stabilization. So obviously a lot of this is going to be heavily influenced by what we know from Dr. Kolach's work in dynamic neuromuscular stabilization. And so everything we've learned about the abdominal wall for the layperson is actually not exactly right. So we can see that the presentation of the abdominal wall when we need the correct stabilization is completely different than what our patients think is ideal, which is the hollowed out stomach. So I'm going to kind of take you through a timeline of core stabilization, and that way we're going to kind of see as the years have gone on how everyone's been able to contribute to what we currently know with stabilization and what we think is right and how to plug that in with our patients. Okay, so this is a picture from DNS, and you can see the picture on the left is actually what we know to be ideal and is what we're shooting for actually. And this is the presentation that we see with a lot of our patients who have low back pain and other musculoskeletal problems. So once the abdominal wall position and function is off, then we have the basically abnormal tone and tension throughout the whole musculoskeletal system. So in a lot of our cases, when we're looking at the rehab side of things, this is one of the first things that we try to fix in our patients. Even in the world of manipulation, when this is not right, we know that it also can contribute to certain joint blockages that we will palpate every day in our practices. Okay, so to his credit, in 1992, Punjabi came out with his joint model or model of stabilization, and a couple really, really important things. So one was we understood that stabilization is actually a two-way street. So we have the receptors in our joints, we have our muscles, we have the receptors in our skin, and this is constant information back to our brain to tell us where we are in time and space. We also obviously have the active system, the muscles, so these systems are always working together. So we need there to be an intent for movement first, of course, but then we need to stabilize our trunks. And that is where, in the last 20 years, we have learned a lot about what should happen when we move our limbs against our trunk. This is a picture from Dr. Hodges. So you can see here their original seminal research came out in 1996. Hodges, Richardson, and the group from Australia. And what they found out was this muscle here in red, this is transverse abdominis. And they found that there's actually a motor control issue or timing of this muscle when people have chronic low back pain. And that was like the start of us starting to understand that this is a motor control problem. So to kind of sum it up, before I move my arms and legs, this should be a subcortical, subconscious activation of our trunk muscles. The hard part that people sometimes get confused is we need this stabilization to be matched to whatever activity we're doing. If I'm going to deadlift weight, it might be 100%. If I'm going to kick a ball, it might be 100%. If I'm walking, let's say it's 20%. And so all of these need to be scrambled by our central nervous system to determine how much stabilization is ideal for the task at hand. We're really excited. In the next couple of weeks, we'll be with Paul Hodges. So Paul Hodges and Collage will be together for the first time. And actually, Stecca will also be there. I will be there also, but we will be kind of hopefully bridging this gap from one of the best researchers in the world in stabilization to one of the best clinicians in the world with Dr. Collage, and hopefully we'll all be able to get closer to be on the same page of what's going on when we stabilize our spine. So this is just the original paper that I was just talking about, Hodges and Richardson in '96, talking about the delayed activation of the muscles. They actually found the same thing with the upper lower extremity and people with growing pain. So no matter where the complaint was in those three areas, they found a delay in the activation of this muscle or the motor control. Okay, so now this brings us to another concept, which would be bracing. So thankfully we had Cole Wicke and Stu McGill, I would say timeline would be early 2000s, where they talked about how it's not just transverse abdominis, it could be internal oblique or other abdominal muscles that also potentially could be delayed in the timing. But I remember when I was younger hearing Stu McGill talk about how, and what he would say is, he was working with the strongest people in the world, and what he noticed is they were always pushing their abdominal wall outward. So at a time when everybody was hollowing their stomach, Stu McGill was kind of the voice of reason saying we need to push our abdominal wall the other way. So what's happened now is we're in a little bit of a conundrum in stabilization where people are getting confused what intra-abdominal pressure means and what bracing means. And they actually both occur. That's a really, really important point. However, they occur at different times depending on what the activity is. And I want to talk a little bit about that here in a second. But so DNS gives us three key contributions to stabilization. So those of you who are familiar with DNS know that one of our goals in our seminars is we are going to use developmental positions in the first year of life, and we know that if we put the patient in the right position and we give them the right cues, then we give the brain the best opportunity to activate all the muscles synergistically around whatever joint we're talking about. Today we're talking about the low back. So within the coursework of DNS, for those of you who have been exposed, you know that we talk a lot about having the right position and also, of course, function of the diaphragm. So you can see on the picture of one of our ideal models for DNS baseball, Tom Seaver, how at this point of late cocking phase of throwing, we have the respiratory diaphragm directly over the pelvic floor. That does a couple things. That allows him to put his shoulder blade in a neutral position on his torso, and also allows him to activate the muscles around the pelvic girdle in the most ideal way. Okay, so this piece of research came out, and this is where Dr. Collage's contribution is so big on what we know to be true with intra-abdominal pressure in the diaphragm. But what they found out was if you have chronic low back pain, the position of the diaphragm is altered. So if we're saying this is the ideal position, if people with chronic low back pain had more of an oblique presentation of their diaphragm. And what this does too is this also creates more tone and tension in the paraspinal musculature and a lack of intra-abdominal pressure from the anterior. So you can see here another good picture. This is just showing how basically everybody knows the function of the diaphragm is for respiration. But as we move along in our life, and we'll say starting at 6 weeks, we start to activate the diaphragm in more of a postural way. So basically the diaphragm now becomes one of the more important stabilizers for us of our low back. You can almost think of it like a canned good or a can of soup, where you have the respiratory diaphragm, transverse abdominis, internal external oblique would be the surrounding of the can, and then the bottom would be the pelvic floor. And it's this canister of stability that is so important, and that is what we were talking about with Hodges' work earlier. Before we move our arm and leg, we need to have these muscles activate and stabilize our trunk first. Our people with chronic low back pain or who don't perform at the levels that we would like them to, oftentimes they have an error in this key stabilizing mechanism. So you can see on this video here, is kind of showing this intra-abdominal pressure that we're talking about. So it's basically no different than a piston. So you can see here, as this drops down, We can imagine in a respiration cycle, the lungs would be filling up with air. They're driving the diaphragm downward. So we're losing volume in the area below here in the intra-abdominal wall or pelvis. So we have this effect going on, which is increasing pressure. But it's not just a gaseous pressure. It's also our diaphragm mechanically pushing against our internal organs. And it's this combination of forces that stabilizes our spine from the front. And this is what we find to be so disturbed in so many of our patients. And you can see here when we activate our hip flexor, I need this to be stable. Therefore, the hip flexor, what's going to insert on my bottom 5 lumbar vertebrae, we want this to be pulling from concrete, literally. So if I don't have this stabilized in the right way, you can see obviously we buckle the chain, which is really a common scenario we see with our patients who all day long they'll be activating musculature against this instability. And the analogy I like to use, it's like shooting a cannon off of a canoe then. So that is obviously not an ideal situation, and it leads to all kinds of musculoskeletal issues. Might lead to disc issues in the back, tension and tone problems in the paraspinals, or eventually joint blockage at the TL junction. Okay, so now this is kind of the confusing part that I feel like everybody in the world is a little bit confused on. So the forces here on the left, this is showing what ideal intra-abdominal pressure does. And I heard Dr. Kolaj speak a couple years ago, and he said that if you have good intra-abdominal pressure, he felt that you'd actually see a decompressing force to the lumbar vertebrae. You can see in this strategy here, we have a compression like so. So if we stabilize with this bracing mechanism over here, then oftentimes it'd be like kind of stabilizing or trying to stabilize 5 oranges through compression this way. You can kind of do it, but as you can imagine, it doesn't work as good. So, but again, this is where we need to have the conversation about during intra-abdominal pressure, it is what we want when we need to separate our rib cage from our pelvis. For example, walking, throwing sports, a golf swing. All of these require me to move my rib cage against my pelvis, all right? So if I was completely braced like this, it is impossible for me to do that. So the brace will be used, and a lot of times the brace will be used at the moment of impact. The best example I got is a martial artist. Yeah, if I'm gonna break boards right now, at the moment I break those boards, you will have an isometric contraction of the abdominal wall, which underneath we would hope that you would have intra-abdominal pressure. So, but up until that point, as you can imagine, as I'm winding up to break the boards, I can't be isometrically braced when I do that. I need to create intra-abdominal pressure by pushing my abdominal wall out eccentrically, and then at the moment I hit the boards, that would be the moment that we would have that brace, if you will. Okay, so you can see here, I'm really, a while back was kind of interested and curious to know what was the verbal cue that we can give our patients to get the right activation. And the one that actually worked the best as far as intra-abdominal pressure was telling the patient, do the opposite of suck in. And you can see on ultrasound here, you can see as the intra-abdominal pressure is generated, we have a pushing out of the abdominal wall. Just to orient you, that's why I love this picture from Hodges again. The red muscle is transverse abdominis, so this is transverse abdominis, this is internal oblique, this is external oblique, this is transcutaneous fat, and that's skin. So ultrasound gives us a really nice look into what is going on with the abdominal wall. So that would be intra-abdominal pressure. Now, when we look at somebody bracing, then we see something totally different out of the abdominal muscles. And this was where I think the proof was really in the pudding when you see the difference. So the cue on this patient was, prepare yourself as if I was going to punch you, and you can see the difference in activation, for example, of internal oblique. So you can see big old activation isometrically of internal oblique and of the other abdominal muscles. So here, this slide just shows you the difference. So this is what the abdominal wall looked like when we were braced. This is when we're generating intra-abdominal pressure, okay? So these are two separate functions, but they're both necessary in sport and life, just depending on what the activity is. Here's a really nice picture again from Hodges showing how from the front of our lumbar spine, what is actually stabilizing us is this compressed chamber of air. As you can see, there's no muscle real close to the spine here, so we need this compressed air mechanism to stabilize our spine from the front. So, early on, those of us who are familiar with the genius Latimer Yonda, we studied, for example, lower cross syndrome, anterior pelvic tilt, and what we weren't talking about then, which we talk about now, is how one of the things that leads to that is inappropriate forces from the front of the spine. So it's not just tight hip flexors, weak abdominal wall. It's also we have an error in this mechanism here. And the saying we always have is you had $1 million to get rid of tension and tone in someone's paraspinals or rector spinae muscle, you would change their intra-abdominal pressure. That's probably the quickest way to have the effect on the low back musculature. Okay, so then what does this all mean clinically, and how do we change this in our patients? So as you can imagine, what our patients are not great at doing is separating stabilization from respiration. So for example, if you're swinging a golf club, you actually basically hold your breath throughout the golf swing. But if you had to carry weight over a period, let's say I gave you two 80-pound kettlebells and told you to take a walk for 50 feet. At some point you have to breathe, so you want to not lose your stabilization when you have to breathe. So if we took all our females who, let's say they're having postpartum incontinence, 20% of them will, they oftentimes will not be able to separate the function that we're talking about. So it's really, really important on the athletic field, which just makes sense if you think about it. If I'm running around on the field, constantly activating my hip musculature against this mechanism, of course it makes sense that I would have to keep some low level of intra-abdominal pressure as I'm playing my sport. So, and that is what I think is the key thing in low back pain in athletes, is they're unable to separate that. But you can see here, this would be an example of somebody doing a good job. So we're able to use a Core 360 sensor and belt. So basically, independent of their respiration, they were able to maintain their intra-abdominal pressure. If you look at this here, you can see the spikes with respiration. So here we have no intra-abdominal pressure mechanism. We just have the respiration going on. So this becomes an amazing feedback for our athletes. A lot of times we'll use, for example, a DNS 3-month supine position where they can start to learn how to keep their intra-abdominal pressure independent of their breathing. And to kind of sum it up, that is like what we're trying to do with so many of our patients. They don't breathe well, but they also don't know how to create the right intra-abdominal pressure. Okay, so once we have this as a prerequisite, then we can start having a little bit of fun with our patients, and we can start to activate some of the bigger muscles. So as I said before, the other added benefit of this conference coming up in Los Angeles is we have Stecco there, who has anatomically dissected out all these different muscles in these slings. And also Andre Fleming, to his credit, also did the same thing also. So if I have this as a prerequisite, now I'm able to use these big, powerful, strong muscles here. And now we have a stable foundation for these slings of muscles to pull from, which is really, really important. In review or in conclusion, in DNS, we're always using the first year of developmental life of the baby to kind of guide us on what exercise to choose for our patients. So if you're not familiar with DNS, that is kind of what we do. Those of you who've been to seminars, you know, to master DNS is to master all these different positions, of course, but also know which patient's going to do well with which different exercise, and then more importantly, to allow our assessment of the patient to drive what needs to be done. And that kind of sums up, I would say, what Annie's doing this week and what we're trying to do, which is to always be able to use the right tool at the right time. You can see here, we'll look at a picture of Rory, or a video. Okay, so what I would like you to notice on Rory when we get to the slow motion part is that there is a moment when he hits the ball where his pelvis actually stops. And what that tells us is there it's not just a sweeping motion of the club coming through where the ball is, and the ball is basically in the way, and that's how we hit a golf ball. But instead, as he's taking the club back, there is a moment where the pelvis actually stops. And that is the exact moment where you're going to have the changing of the function of these muscles. At that moment, then we have an isometric contraction. But up until that point, we have stabilization, pushing out. And then as I come back to the ball, then right at the moment of impact, there would be an isometric brace of these muscles, and then I would back off and we'd be back to intra-abdominal pressure. And as you can imagine, our golfers who aren't very good, they of course do swing through a brace. They have that golf swing that kind of looks like this. They're swinging through rigidity. But we know the best athletes in the world, they generate the right intra-abdominal pressure, and then they can relax their muscles and explode off the right stabilization. And that is one of the hallmarks of good athleticism. Since it's baseball season, you can see here, Stanton, we have the exact same thing. So, and another hallmark to really good movement, and we teach this at DNS, is that before we start to rotate, we need to transfer our weight, transfer our forces, and then at that point, we're able to use the intra-abdominal pressure mechanism and use these big, powerful muscles to help us. So we would never start the rotation too soon. The rotation between the rib cage and the pelvis are always coordinated together. And that allows us to, again, be able to relax our muscles, explode our muscles, and relax again. The people who are really good at this, we call them neurologic savants. So this is important on the athletic field. If there's anyone out there doing manual therapy and manipulation, it also becomes really, really important to get it right in our bodies to be able to generate the right force. And then again here, so at the moment of impact, this is where the function of the abdominal wall is going to change. So we have a brace at the moment of impact, and then up until that point, we're probably going to have more intra-abdominal pressure. And it's basically the same through all these different athletic events. I think one of the reasons why people have gotten confused is the term that gets used as intra-abdominal pressure. Sometimes people, when you hear intra-abdominal pressure, you think of it being like a Valsalva maneuver. So that is not necessarily what we're talking about. So I think that is part of the reason for the confusion. And then you can see here, just in human walking, so you can see here, if I have good hip extension and good arm swing, I have this cross-hatching effect that occurs between my torso and my pelvis. So I'm able to activate these different muscular slings. Underneath, I need the ideal intra-abdominal pressure. If it's not ideal, obviously my own muscles start to create aberrant forces through my back. And you can see here from Greg Kavetsky, he originally talked about in the spinal engine that this person's allowed to walk without femurs because of coupled motion of the spine. Now I think at DNS, we totally disagree with that probably. We think that the reason this patient is able to walk is because we're able to generate not only intra-abdominal pressure, but we're able to activate these abdominal slings. Another concept in stabilization is making sure our joints are in the right position. So if you looked at even one of the top ping pong players, you can see he always will put his joint in the most advantageous position. So when we use the term joint centration, what that means is my brain now is given the best opportunity to activate all the muscles around whatever joint that we're talking about. So can you still hit a ping pong ball with your knee in valgosity? Well, you can, but your ability to use ground reactive forces and activate the right muscles around that joint will be a little bit disturbed. Jim Abbott's a classic example of that. So you can see Jim Abbott, just an unbelievable story. He did not have a right hand, but he also had his knee in this position. We never see this in present day Major League Baseball pitchers. So it tells us how intertwined the kinetic chain is. So him not having a right hand is related to his knee position. Here you're looking at Tim Lincecum, and you can see as far as joint centration, you couldn't draw a more perfect line with a ruler. And then the third component of DNS that we really like to talk about is how important multisensory integration is. So said a different way, the better you can feel your body, it's called gnosis, then the better you're able to stabilize your body. So a lot of us as manual therapists and rehab specialists, we actually have a huge contribution here because we can do things to our patients to allow them to feel their body better, which will always equate to better stabilization. And these are absolutely intertwined together. And then just some closing quotes from Collage on this topic. Sensory and motor functions are very closely interrelated. Correct sensation is the foundation for good quality of any desired movement. So being able to assess this on our patients is paramount. In conclusion, I would say we are lucky and honored to have Annie O'Connor in World of Hurt here this weekend as she teaches us how to properly classify central pain. And we are really looking forward to the weekend, and we will talk to you guys soon. Thank you.
Wow, Brett, that was fantastic. And what an opportunity it is to collaborate on this level of showing where systems fit in. And as Brett came from the chain, I'm probably going to come from the brain in the sense at talking about pain. Because we are really hitting it hard, people, in the respects to people come for function and people come for pain. And where are they on that continuum of function to pain is a huge part of disability. And we're serving that. And so I want to just openly thank Gestalt Education for hosting a World of Hurt course this weekend and Winchester Spine and Sport for putting this all together. But my opening's going to come from service to the patient, because that's what we are. We're serving the patient. And we may have to take our professional foundations to try to organize that information to ultimately serve the patient, but that's where we are. And so when we just go and say, what does the literature say? The literature says to us providers, hey, explain pain, explain the brain's role in pain to why they hurt. And we need to be able to figure out how to do this. Is it a function problem or is it a pain problem? Well, what does the literature say with respects for the patient? The patient is saying, why do I hurt? And let's agree, sometimes it's not about where, it's about why. And I think sometimes we've gotten lost in the where, and we've got to revisit the why. And so as I go into this discussion about that in the sense of this PowerPoint, I want to take it from this idea behind pain mechanism classification, and I want to talk to the providers, and then I want to end this on how do we tell that to the patient. Because this is really about us parlaying information from us as a provider to that patient. So we all know, if we talked about definitions, and I love Butler and Mosley's new definition on pain, in the sense of them explaining this is something that comes from the unconscious into the conscious. And it's this simplicity, because the brain is so complex, but the simplicity behind, hey, if I have pain, my brain is actually thinking protective. And that means if pain's going to exist, the credible evidence of danger in my life is greater than the credible evidence of safety. Because my brain is going to protect me and pain is going to be the part of that. There's going to be a symptom, whether it's a pain symptom, a tingling, a numbness, an ache, a tightness. The description lies within the interpretation and the perception. And no, the brain's going to err on the side of protection. It is wired to do that. You don't get pain without a brain. Now, can we be so bold in this day and age of pain treatment? Get out of pain management. I don't want to go there yet, but pain treatment to say that pain doesn't have to exist. It does not have to exist. But that's us, providers, the defense lawyers to the body, being able to say, is there enough credible evidence of safety to outweigh that credible evidence of danger? Where I can shift the brain into not thinking it has to protect. And that's our biopsychosocial approach. That's what it's all trying to tell us, to say that, hey, there is a mechanical side. And that's exactly what Brett was talking about, that really unique function element to pain that we have to be good at doing, because that there is a mechanical side to pain. There is a nociceptive side to pain. Nociception is huge. And I know the pain science world is nociception doesn't equal pain, but we got to explain what that signal means. There is a signal coming in. And is that signal saying that I'm inflamed and then I need a certain inflammatory mediator to abolish my symptoms? Or is that signal saying, hey, I need a better breath stabilization model for me to execute a high-level function? That signal's saying something. Or have they morphed down that continuum and there's a neurogenic element to this? What do I do when there's nerve pain? Or have I left this mechanical influence of nociception and I'm actually into a nervous system, central nervous system problem, whether this is central sensitivity, an effective mechanism, or motor autonomic? I've moved on this continuum. And every visit is a reassessment of that data. Mark Miller, I love the guy from the McKenzie Institute. His quote on, I don't treat, I assess until there's nothing left to assess, is a very powerful quote because it's saying to us, hey, provider, where am I today? And which way am I going? And can you use your words and your moves and maybe your foods to alter this continuum? Because that's really what we're about doing. And that's going to be the collaboration and the integration of multiple systems. It's never going to be one system. It never will be. And why I've kind of fallen in love with this pain mechanism classification approach, because it makes me honor that reassessment. It makes me think about where my patients are, from the movement side to pain to the nervous side to pain, and make sure always that my words and my moves and my foods are geared toward that mechanism. It's not a replacement for the pathoanatomical system. It's an enhancement of the pathoanatomical system. We have to know when to use that system versus this system, and that's our challenge. And it shouldn't be a Twitter war. It should really be a collaboration. But Gifford and Butler came out with this system in 1997, and Smart et al. Did the research in 2010 and 11 to ground it on reliability and the beginning signs of validity. And then the co-author, Melissa Kolsky, and myself have taken that on in research in 2016. And actually, the book coming out in 2015, The World of Hurt, which is 25 years of practice in a large urban rehabilitation hospital that specializes in disability from function to pain, from neurologic to musculoskeletal, applying this in about every level that you can imagine, from spasticity to dystonia to ataxia, to high-level performing athletes, to people with traumatic brain injury. I mean, we are really about figuring out the common language to why people are hurting. Is this an input mechanism from the body, inflammation? Is this an input mechanism from the body, a signal of ischemia? Is this a nerve-related problem? Or has this now become something central nervous system, that integration of the DRG into the central nervous system in the brain? Or is this just completely an output mechanism relative to the brain and involving the primary motor cortex or the emotional social areas of the brain? And that's really understanding pain. And how do we explain that to the patient? Well, we can't explain it to the patient until the provider is operating with some level of explanation. And I can guarantee you, those that are listening, thank you very much for listening, I am not telling you anything you don't know, but I am organizing it in a way that you possibly haven't thought about it before. So it doesn't require a certification, it just requires sometimes a reorganization of knowledge. And we all get inflammation. We all get the chemical side to inflammation that actually initiates with injury most of the time. And we need inflammation. It's our first stage of healing. And it's very chemical, and chemical things are actually the mediators for that. But we also, from the great literature and the great work of the McKenzie system and treatment-based classification with specific exercise and derangement, have recognized the whole idea behind a mechanical inflammatory side to inflammation, where there is the sign of directional preference, where moving them in a certain direction can abolish symptoms very rapidly. And that's a real entity. And David and Louis always put this under an inflammatory mechanism because you move them in the wrong direction, more than likely they're going to become chemical. And this is a goal. Isn't this fun? Because the goal of this mechanism is abolish my symptoms. Whether I abolish them through non-steroidals, steroids, ice, or I abolish it through directional preference, that's the goal. But that changes when we start talking about the other mechanism from a nociceptive level called ischemia. Ischemia is just really recognizing that target tissues, whether those are cartilaginous, ligamentous, tendon, muscle, inert, or contractile, become devascularized. Now we're in the stages of healing, of repair and remodeling, where we actually have to load tissues. And now we all know that this tissue remodeling part of our rehabilitation programs may become much more prevalent. The fun thing about this mechanism is now it's like a 180 to inflammation, because now we all know we're going to produce pain. We're going to increase pain. We'll be no worse in 15 or 20 minutes, and we consider that safe. But the goal here sometimes is not to abolish as much as it is to produce. And this is a 180. And boy, it is very important as a provider to know when you're in that inflammatory abolish or ischemic create. And are you really a tissue problem, or are you a function problem? Where quality function and everything we just talked about with the DNS approach, honoring our development in the motor programs inherent within our central nervous system, become hugely important, built off of our breath system. Brett did an incredible job talking about the importance and intricacies of training function under an ischemic mechanism. And we have to be that succinct, especially when we're talking about sports performance. We have to be that succinct when we're talking about somebody with a hemiplegic CVA, musculosclerosis, whatever they call them. And I don't even know, I don't use diagnoses anymore. They became irrelevant to me. But we have to be that succinct for that person to be able to ambulate, and ambulate efficiently and effectively. But that's an ischemic mechanism where I may allow pain to happen, and pain is safe to happen. And how do I parlay that into my patient? Now, what happens when we have a nerve-related symptom? I thought this was very interesting that David and Louis, when they put this system together, actually had a classification or a subgrouping that honored a tissue, the peripheral nerve. And when I got to ask them the question, like, hey, why did you do that? It was very clear that they did this to make the provider think, hey, is that nerve outside the dorsal horn, nerve root, nerve axon, cutaneal terminal branches, getting trapped somewhere? There's a snag in the system somewhere. Thereby, I should be directing my care to certain entrapment sites, maybe like an HMP that's reducible with certain exercises causing centralization. Maybe how I do foraminal opening procedures to create more space in a space-occupying lesion. But I got a bit of a trapped nerve. Maybe how I stretch a scalene, lower a first rib, move a carpal bone, because that nerve's getting trapped somewhere along the path, versus when that nerve's just gotten tight like any other tissue. And I need to get into those specific neurodynamic loading procedures to actually rebuild the inherent tensile load of the peripheral nervous system. That is one long, strong tissue. And my ability as a provider to say, one, I've got a nociceptive input mechanism relative to the peripheral nerve, and it's needing me to either focus on the entrapment site because it's testing trapped versus it's testing tight, is a very critical call in the management of somebody who's having neurogenic symptoms. Now, This is all good when we talk about inputs into the system, nociception, and that mechanical side, where our moves are going to be incredibly specific. But what happens when things start morphing now along that continuum into the nervous system side, and we get what's been termed central sensitivity, where now we're dealing with the dorsal root ganglion, the little brains in the spinal cord that actually have gray matter, that make context decisions on inflam or anti-inflam to every nociceptor coming into the system. A very cognitive mechanism where people are actually misinterpreting what that signal means. Because you got the thalamus and the amygdala involved, the fear and threat centers, that actually have to scrutinize every nociceptor to say, should I protect that one or should I not protect? Some have called it the fear avoidance behavior mechanism. I think that's a good one for things, because these smart people somehow now are threatened by that signal because they don't understand it. And because of that, the system sensitizes itself. And because of the unique locations of the DRG, they form interneurons and can actually sensitize other pathways, and widespread pain can happen within minutes. But this is an input mechanism affecting an output response versus the two known output mechanisms. One, what's been termed in this system the effective mechanism, but boy, we could throw up a lot of other words. We could put psychosomatic. We could use mind-body disorders. We could use psychological. We could use somatization. All of these words have referenced the great ability of the brain, and it's happening in all of us, and we probably all have had this happen at one point in time, where the insular cortex, prefrontal, anterior cingulate, lateral orbital, or what we always call the patients, the emotional social centers of the brain, where how cool is it that your brain can actually recognize you may not be coping so well. You're not coping with anger. You're not coping with anxiety. You're not coping with things that have happened to you relative to this trauma. Holy cow, I don't know if I can get back on that field. You're not coping with things that you've repressed, inferiority, shame, resentment, guilt. And your brain's like, wow, man, she ain't coping with this. She's losing control. You know what? She's got to go get some help. I'm going to pick some important body parts that she thinks is important. And I'm going to create symptoms in that body part, and she'll go get help. Well, me as a provider, I've got to realize that the issue is not with the tissue. The issue is with the brain recognizing that they're not coping and using the body. Because these pains are real. And the cool thing about how people get pain this way is that brain actually can deoxygenate a tissue. Your brain can decide that your Achilles tendon doesn't get blood flow. I'm sure that's going to feel a little odd when you're on a 26.2 mile run. Your brain can decide that I'm going to just shut some blood supply off to that supraspinatus. And I'm sure that's going to be a bit of a problem when you're trying to decelerate a load. So how do I know it's this mechanism versus something very ischemic where the tissue doesn't have a good blood supply? And that's in the characteristics of what we've come to learn with pain mechanisms, and why I'm very excited to be working with Gestalt and teaching a world of hurt and the pain mechanism approach. Well, the last on that continuum, why somebody could hurt, is this whole idea behind the motor and sensory cortex. The disembodiment that people may go through relative to trauma, actual trauma, perceived trauma. People have called this phantom pain. We find huge applications for DNS in this mechanism as well, because this is dealing completely with your motor and sensory cortex. And that's the premise of what DNS is is the ability to reactivate some of our inherent motor programs that are relevant to our development. And whether I use breathing as a way in, or whether I use a developmental movement pattern as a way in, or whether I start doing left-right discrimination because this person has lost recognition, they've lost those inherent abilities to recognize left versus right, or from a sensory perspective, localization and precision, graphisia, stereogenesis, which are all relative to this sensory motor mechanism. This poor patient could be glaringly as bad as CPRS 1 and 2 to a small little axial low back pain that seems to not have responded over years and years and years. And so again, as a provider, I got to be able to know where are they on that continuum, because this approach needs a sensory motor approach. And it probably is going to parlay into a functional approach that looks very similar to a DNS functional approach. But I'm going to have to work on the brain before the body with left-right discrimination and localization and things of that nature, and use imagery. This is where graded motor imagery fits in, and the great work that's been done through the NOI Institute. Well, with that, that's what a World of Hurt's been always about. For 25 years, we've been applying the pain mechanism classification system into function disability and pain disability. And really, it is about pain and disability are the victim. Negative words, moves, and foods are the culprit. So positive words, moves, and foods are going to be the cure. But how do we pick that up? Now, when we talk to patients, how do we as providers, you allowed me to lay this down and lay it down a little bit in the process of taking your foundational knowledge into service knowledge. But now where do we go with the patient? Often we talk to the patients about this idea behind the 5 steps to a pain-free life. Because we talked about explain why they hurt, explain the pain alarm system, allow them to know that the brain is a big part of that system in a non-threatening, non-psychological way, because pain is real. And it always will start with, hey, step 1, we use the lamp analogy. If your lamp didn't work, what would be the first thing we would all do? We'd go and change the light bulb. We'd start flicking switches to make sure that that lamp had some type of electricity going to it. But if that didn't work, we'd be quickly moving to step 2 in the sense of, hey, did I plug the cord in? Am I working with the electrical cord? Well, what is that in the body? If I kind of say, man, if I'm hurting, what's step 1? Well, step 1 is to identify, is there a chemical inflammatory process going on? Is this a first stage of healing? Or am I ischemic? And the varying differences between looking for things that abolish pain in directions and chemicals versus looking things that may need to be remodeled, whether they're tissues or functions, that's step 1. But if step 1's not working, if my outcomes aren't changing, I don't continue to just show them different light bulbs. How many elbow surgeries does it take before you start looking to the nerve to the elbow? And is the nerve to the elbow tight or trapped? Well, let's talk about I'm changing light bulbs, I'm flicking switches, I'm plugging cords in, my lamp still doesn't work. The beautiful thing of step 3, like let's check the circuit breaker. Maybe it was that sister again, blow drying the hair, running the microwave. She blew the circuit. No wonder my lamp doesn't work. Well, what is that in the body? Hey, maybe it's the fear and threat centers to the brain misinterpreting what the signal really means. The signal all along was just saying, hey, you need to get a little stronger here. But the brain's going, wow, man, you're blowing out another disc. And that disparity between what the person thinks is the problem is a huge issue at this point in time. But when are we going to leave what's seen to go what's unseen? And if it isn't something relative to fear or avoidance behaviors, the bravery it takes to go to step 4 with a person and say, hey, I think some of the triggers to your symptoms are relative to these social situations or these emotional situations. Because we all have them, and they're normal. And how brave is it when your lamp goes out that you're brave enough to call the electrical provider and say, look, buddy, you got my power out again in my area. Because that would be naturally the next step if my lamp didn't work. But would we take our patient that far in the emotional social centers when their body still hurts? Not making them feel psychological, but let's talk about good old-fashioned coping. Well, I'm coping, I'm doing everything, I'm breathing, I'm thinking right. I still hurt. There's only one other thing left. Relative to the body, it's, hey, maybe I've lost recognition between the brain and the body, and there's a reorganization going on within my motor and sensory cortex. And that sensory motor approach is going to be the key for me to reset that circuitry. And we know this already in our lamp, because if it's not a power outage, it's not the circuit breakers, the only other thing left is the little box on the pole is not recognizing my home, and the little man's got to come out to the pole and re-image my house to that box so that the electricity can actually come. So we understand as we talk to patients and we say, look, you have tried injections, you've had tried directional preference, you've tried how many different stabilization programs, you've been to how many neurodynamic providers. We can basically show them why those interventions haven't worked. It's not that the system has failed, it's just that we haven't gotten the right treatment for the right mechanism at the right time. And that's the great work that's happening out of Gestalt with the collaboration of the systems that you're bringing in here. And I can't tell you and thank you enough. I hope my passion isn't too much for anybody, but the opportunity to collaborate with the system on a function to pain level, talk about pain mechanisms as it relates to function, and where are we on this scale, and to parlay that information to that person in front of us and how we get them to understand that. It's beyond an honor, Brett.
What you're on.
Okay, guys. Well, I hope you guys enjoy these 2 talks together with these guys. I think that we learned a couple things just from this little bit. Number one, no one system encompasses everything, right? Like if you're a slave to a system in a treatment room, it's going to be really difficult for you to get everybody better, right? You may get a certain section of people that'll conform to your system, but if you don't have multiple different approaches and knowing when to use them, then you're almost lost, right?
Amen.
And so using your assessment, number one, to drive what to do next. That's basically what each of you talked about is knowing when the assessment matters and what's the most important topic there, and then going that direction, right? You can always switch gears and move directions and stuff, which is why we don't have just one thing up here, which I think is what's so cool about us going forward and getting these people together to talk and have conversations like this is that we need to have these difficult conversations and to figure out how they blend. And maybe they don't. Maybe it's not always clear cut and easy, but that's what it's all about. That's what it's all about, is getting them to talk and have difficult conversations.
I think we all think that we can always just take a patient and once we decide what track we're going on, that's all we're going to do. And when I look at, my average patient that I see, I'm dancing around in all these different systems depending on where they're at in their healing stage, what I need to do with them. I mean, a lot of things are going into that decision. So I think that can also be a mistake, is we think, once I've made this decision, that's where the patient's going to stay. And I think that, and there's more, but this is the ones that we think that, we use on a day-to-day basis that we think are really important. These up here are kind of our core 4, just because, and we're talking about the peripheral system now, but because you will run into a patient every day of your life that if you don't know, for example, the neurodynamic piece, you're not going to have a tool for them. Or we're kind of homers for chiropractic. If you don't know how to joint plane, you don't know how to manipulate, there may be somebody in your day that you're not going to be able to help, obviously. So in all these systems, they have their place. And what keeps me up at night is I have a wall that looks like this in my basement, and I basically am shifting things around to decide, okay, this is the place for this, or maybe, we hear a new soft tissue technique or whatever it might be, and this is its place. Like in a couple weeks, we'll be around Stecco. So I'm kind of fascinated to know, like, where does that fit in our model? So that is kind of the gestalt, right?
That is it. Yeah, absolutely.
Well, it's what's completely amazed me with Gestalt is how readily you guys have figured out these different systems and have put them in a model of education that allows us to groove the foundation that we have. Because it doesn't matter whether we're chiropractors, physical therapists, occupational therapists, psychologists, medical directors, medical doctors, it doesn't matter. We all came out learning the human system, pathology, anatomy. Now, how do we take pathoanatomical, know when it's right, because it has its purpose. That's Red flags is pathoanatomical. How do we know when that's right to get into yellow flags when we're probably in the brain? To get into the ability to know directional preference versus remodeling tissues versus quality function versus neurodynamic. I mean, that's huge. And you guys have really put together an educational institute that has taken that forward, allowed interdisciplinaries to come under one forum to learn together so we can have those tough discussions. It's a pleasure and honor to be a part of it, but I just really want to give you guys kudos. There's not many educational institutions that have really figured that out.
But I think, for the reason we're together this weekend is this can all be perfectly in place, but if we're dealing with more of a central case, then it doesn't matter how good we are at integrating all these other things. And that is where World of Hurt has really come in, and I think is changing the landscape on what we do. And that's why it is such an important part of what we're doing, because of what Annie said. We just don't know here we call it the BOS, which is the bag of shit that the patient is going to bring into the room that, a lot of times doesn't come out,
No.
But anyways, it's going to reflect on, maybe how they're reporting their pain that day. And if you're not paying attention, like, you miss that. And it's a really, really important part of what we do. And we need to be sure that not just in the peripheral system, but also the central nervous system, we're able to also categorize these patients. And then once we're able to do that, then we're able to treat them better.
I appreciate that. I agree that, we have learned a lot with the application of the pain mechanism classification system in the central nervous system and identifying those three mechanisms and the uniqueness of the patient education that has to occur, the characteristics that we're going to cover, right? I mean, that's the whole premise of the World of Hurt training, is taking the pain mechanism classification system into characteristic and patterning. Pattern recognition is how quickly you can get to that point.
What do you think the next 5 years look like, Annie, in pain classification? I mean, is it changed?
To be honest with you, from the grants that we're working on, it's the validation and reliability of the three central characteristics. You're going to see it happen. You already read about it in the pain science literature. You read about it in the brain pain physiology literature. But no one's gotten it to the clinical, characteristical, practical application in a statistical model. But I think you're going to see that come over the next 5 years.
Man, that's exciting.
Yeah,
that's amazing.
If you're on board as a clinician, because we all know, come on, clinicians, the N of 1 sitting in front of us is what innovation is. If we can't do the N of 1 well, we can't get to the N of 100, the N of 18,000. We can't. So we do have to be able, on an evidence-based practice platform, to be able to be willingly to be ahead of the evidence. Practice is ahead of the evidence.
It's an uncomfortable position, right?
And what you're doing in the clinic is literally 10 years ahead of what you'll read in a journal. And it's probably 20 years ahead of what we got going on in curriculums. And that's why curriculums will invite gifted clinicians to be a part as guest lecturers and as part of adjunct faculty, because they know that. So it's an important piece, but that's where I see things kind of heading, is the actual validation, statistical reliability of those central characteristics. We've been doing it for 25 years, So yes, we should have published already. But in the mindset of what that means, you have to get clinicians on board doing the same thing. If you can't make the hamburger the same,
Yeah.
there's no credibility in the intervention.
How do you guys in the hospital system, because some people like yourself, you have an amazing ability to heal with your words and things like that. So some other person could say your exact words, but maybe not say it as well or as empathetic. So anyways, in a system, how do you capture the people that are really good at delivering the message? They may have the content down, but their delivery is not quite
What you guys are going to experience over the next 2 days is what we like to call our scripts. Look, come on.
Couldn't mess it up if you tried.
You couldn't. And everyone has their own flair. And let's all agree the therapeutic alliance with the patient is the foundation by which this can happen.
Right.
And that cohesive partnership we have is how the acceptance of new knowledge can happen. So a script, right? We all saw Wizard of Oz, and I'm sure we've seen different actresses play Dorothy, and we all liked every one of them because it was the same script.
Yeah.
And that's the reality of where we've come. We've come to the point where this is the script. Explain the signal. Explain what the signal means.
Wow.
Okay? And so if we can impart that, into the world at this point in time, because it's now allowed to happen. I mean, that approach existed in a hospital, and it wasn't until 2015 where it was allowed to come outside of it. Okay? But it was applied through interdisciplinary providers and carers, and everyone saying the same word, making the hamburgers the same, saying the same thing. And so we know that those words work.
Yeah.
We've got the scripts. And everyone's a little different with their, improv and their acting ability and,
their certainty.
And their certainty and their confidence and competence in that. But ultimately the therapeutic alliance you have with the people that you serve is going to give you the foundation to apply that information.
Wow.
Perfect.
That's good, man. That was awesome, guys. Amazing. Thank you so much. That was awesome. Well, I hope you guys enjoyed. I hope it gave you a little bit of a glimpse into kind of how these two amazing people think, and stay tuned for more of these kind of not necessarily difficult conversations, but necessary conversations. That's what maybe the name of this should be, is necessary conversations. And we can't wait to see you next time. So thanks again.
Thank you.